Malnutrition occurs when there is deficiency in intake of essential nutrients, that is, proteins, carbohydrates, fats, vitamins, and minerals. And it is most commonly seen in children less than 5 years, particularly after weaning. It reduces the individual's ability to fight disease and also infections, thereby increasing the likelihood of the patient presenting with diarrhea, vomiting, fever, worm infestation, pneumonia, tuberculosis, even otitis media, urinary tract infections, among others. In adults, malnutrition frequently occurs in association with chronic alcoholism. Protein energy malnutrition, when severe, presents in different forms such as marasmus, kwashiorkor, or marasmic kwashiorkor. Birth space and through family planning, as well as exclusive breastfeeding for up to 6 months, followed by introduction of weaning diets at 6 months and continuation with complementary foods for up to 2 years, may be very helpful measures in preventing malnutrition in young children. Encouraging a balanced diet for the family, including pregnant and lactating women, and nutrition education in schools and several places may help reduce the prevalence of malnutrition in the community. So causes are poverty, inadequate quality or quantity of food intake, also social neglect, repeated or chronic infections, repeated diarrheal illness, worm infestations, HIV, pulmonary tuberculosis, measles, pertussis, and also chronic illness and cancers, alcoholism in adults, and several others. Symptoms are weight loss. Usually there's a drop or flattening in weight on the child health record. Also poor weight gain, body swelling, for example in kwashiorkor, and also child plays less because of lack of energy, and there's disinterest in food and surroundings. Signs that are usually elicited for marasmus include hanging skin folds, especially over the buttocks, also prominent bones, thin, reduced muscle bulk, unusually alert, looks like an old man. For kwashiorkor, puffy face and legs due to edema, thin and wasted arms, brownish or reddish hair, flaky skin rash, especially on the legs, sores on the edematous parts of the body in severe cases. Also, miserable and disinterested appearance. There is this interest in food, and for anthropometric measurements in moderate acute malnutrition, the mid upper arm circumference is usually between 11.5 to less than 12.5 centimeters, and weight for age is usually less than -2 z-score, but greater than -3 z-score. And the weight for height is usually less than -2 z-score, but greater than -3 z-score. And for severe acute malnutrition, the mid upper arm circumference is usually less than 11.5 centimeters for age 6 to 59 months, and the weight for age is usually less than -3 z-score, and weight for height too is also less than -3 z-score. Investigations: FBC, urine electrolytes, serum albumin, urine culture and sensitivity, blood culture and sensitivity, chest x-ray, HIV testing, gastric lavage for acid fast bacilli, and also screen for common infections such as tuberculosis, pneumonia, and urinary tract infections, among others. So the main treatment objectives are to identify and treat associated infections and complications, and also to correct fluid and electrolyte imbalance and other complications, and to correct the nutritional deficiency, including vitamin A, and also to prevent recurrence of the condition by educating caregivers, and to adequately manage chronic illnesses. Non-pharmacological treatments include nutritional rehabilitation for outpatient care. Malnourished children who have appetite and do not have any overt medical condition which requires admission should be managed as outpatients with ready-to-use therapeutic food. And also inpatient care, admit all severely malnourished children who have medical conditions requiring inpatient care. At the stabilization phase, frequent feeding with F75. Also introduce ready-to-use therapeutic food as RETF, and progressively return to acceptable balanced family meals. Participation of parents and caregivers in nutrition education. For pharmacological treatment, vitamin A supplementation in children. You give vitamin A oral in children more than a year old. You give 200,000 units daily for 2 days. Between 6 to 11 months, you give 100,000 units daily for 2 days. Less than 6 months, you give 50,000 units daily for 2 days. So vitamin A supplementation should be given to replace body stores, except if the patient is on RETF, that's ready to use therapeutic food, made according to WHO specifications, which already contains adequate vitamin A. Also, for treatment of underlying infections in children, you give for inpatient cefuroxime IV 20 milligrams per kilogram 8 hourly for 48 to 72 hours, and then you give cefuroxime oral for 3 months to 12 years. You give 50 milligrams per kilogram 12 hourly for 5 to 7 days. For outpatients, you can give amoxicillin oral 5 to 18 years. You give 500 milligrams 8 hourly for 10 days, and 1 to 5 years you give 250 milligrams 8 hourly for 10 days, and for 1 month to a year you give 125 milligrams 8 hourly for 10 days. Also, you can treat worm infestations and also immunize children. For referral criteria, refer to appropriate specialists for management of the underlying cause. Also refer to reproductive and child health units for family planning services, and also social welfare department within the health facility, district or region.